My name is Shri Ghadigaonkar, and today we're going to talk about cardiomyopathies and myocarditis. So these are the important points that during the exam you need to mention. And as you mention them, you can just go on talking about them. So these involve cardiomyopathies. So you always need to mention what it actually is, including the definition. You have three specific types. These are the most high yield ones. So dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. You also have certain others that we will briefly talk about. And you have myocarditis. So yeah, so first we have cardiomyopathies. So what is it? So cardiomyopathies are cardiac diseases due to intrinsic myocardial dysfunction. And these must not be due to hypertension, ischemic heart disease, valvular heart disease, or congenital heart disease. So the etiology can be primary or secondary, and primary, these usually involve genetic factors, and usually they have a poor prognosis. Secondary factors can be infections, so these could be, for instance, bacterial infections, they could be viral, for instance, they could be fungal or even parasitic. You can have certain toxins as well, like alcohol, carbon monoxide, narcotics, for instance. Regarding endocrine and metabolic causes, you can have something like thyroid hormone abnormalities, for instance, and you can also have allergy and autoimmunity. For instance, you can have like lupus, which is pretty common. So this is just a generalized overview to to show you how morphologically a heart would look like when in specific cardiomyopathies. So this is your normal one. You have dilated cardiomyopathy, as you can see the dilation of the chambers. You have restrictive, which is, we'll talk about that briefly, and hypertrophic cardiomyopathy. So the first one is dilated cardiomyopathy, and you always need to start off with a definition. This, a dilated cardiomyopathy is defined as a progressive dilation of all four chambers of the heart, leading to systolic dysfunction that results in congestive heart failure of both sides, or biventricular congestive heart failure, and it may or may not be associated with concurrent hypertrophy. The etiology, again, it can be primary or secondary. Primary usually involves genetic factors like certain mutations of important cytoskeletal or sarcomere to cytoskeletal connective proteins. So these are some of the proteins out of which the most commonly mutated is titin, and these usually have a autosomal dominant inheritance pattern. Secondary can be acquired or idiopathic. These are more common. And there's a specific mnemonic I have here for you, which is widely used. So you have A, B, C, 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 D, and Harry Potter. So in this, you follow alcohol abuse for the A. You have beriberi for the B. So that's vitamin B1 deficiency. You have Coxsackie B virus for the first C. You have cocaine use, second C. Chagas disease for the third C. And doxorubicin toxicity, which is a chemotherapeutic drug for the D. And in the Harry Potter, you want to focus on the H and the P, where the H stands for hemochromatosis. So it's basically systemic iron overload, and it can also cause restrictive cardiomyopathy as well due to interstitial fibrosis. And the iron overload is associated with reactive oxidative species damage. And the P stands for peripartum cardiomyopathy. So this usually happens during the last month of pregnancy. Um, or up to 5 months after giving birth, and it usually has a multifactorial etiology. So, for instance, pregnancy associated hypertension, it could be volume overload, nutritional deficiency, etc. And these basically lead to destruction of muscle fibers, and hence you have, and therefore you have dilation. Regarding the morphology, so in pathology, you always want to mention the definition, the morphology, so the pathological aspects, how it looks like macroscopically, microscopically, and you want to mention the complications. So with regard to morphology, the heart in dilated cardiomyopathy is enlarged, and sometimes it may be even 2 to 3 times the normal weight, and there's dilation of all chambers. The ventricular thickness may be variable. Most myocytes exhibit hypertrophy with enlarged nuclei and variable interstitial and intercardial endocardial fibrosis is present, and also mural or intracardiac thrombi are often present. Regarding the clinical signs, so they're usually associated with ineffective contraction. So you have signs of low cardiac output and congestion, decreased ejection fraction, and a systolic murmur on auscultation, which is usually of a regurgitant type. Regarding these signs of congestive heart failure is usually dyspnea, fatigue, poor exertional capacity. So in this slide, I have a picture for you associated with a dilated cardiomyopathy. As you can see, the four-chamber dilation and hypertrophy are quite evident over here. As well, a small mural thrombi can actually be seen at the apex of the left ventricle over here. On the right side, you have the non-specific histological picture, which is usually typical in dilated cardiomyopathy. You can actually see the myocyte hypertrophy, and this blue thing over here is basically collagen, which indicates interstitial fibrosis. So the stain specifically used is Mason trichrome strain. And yeah, so this is your microscopy and this is your macroscopy. And finally, we have the complications of dilated cardiomyopathy. So this is biventricular congestive heart failure, which leads to high pressure, and this may propagate to the lungs and right heart. You can also have secondary arrhythmias. So if you think about it, when the heart is stretched in dilated cardiomyopathy, the conduction system is also stretched, and this can cause certain issues during the conduction. As a result, you'll have arrhythmias. You have mitral and tricuspid valve regurgitation. So if you think about it, the heart as it expands in dilated cardiomyopathy, the the papillary muscles associated with the cusps also get pulled apart. And logically, if you think about it, when the heart contracts, the cusps are unable to completely shut. As a result, you have regurgitation. Have embolism, so the mural thrombi can actually embolize from the heart, and about 50% of the patients die within 2 years. And this is usually due to arrhythmia or cardiac failure. And you have treatment over here, but the examiners most likely won't ask you treatment. But I feel it's good to remember some of it at least, like transplantation, diuretics, ACE inhibitors, beta blockers, mention that again, and digoxin. Regarding hypertrophic cardiomyopathy, so we start with the definition again. It's hypertrophic cardiomyopathy is characterized by myocardial hypertrophy, defective diastolic filling, and in some cases, ventricular outflow obstruction. So I have a good picture for you in the next slide. Uh, it's also known as asymmetrical septal hypertrophy or idiopathic hypertrophic subaortic stenosis. So regarding the etiology, it's usually most like 100% it's genetic causes. It's usually a missense mutation in one of the several genes encoding sarcomere protein. So this is again autosomal dominant inheritance. You also have Friedreich ataxia, which is another genetic cause, which is autosomal recessive inheritance. So regarding the morphology, so in the word itself, you can see hypertrophic. As a result, you have massive left ventricular hypertrophy, paradoxically associated with a markedly reduced stroke volume as a consequence of impaired diastolic filling and overall small chamber size. So the picture on the next slide will make it much clearer. You also have reduced cardiac output and a secondary increase in pulmonary venous pressure, causing exertional dyspnea, myocardial ischemia and atrial fibrillation with mural thrombosis, as well as ventricular fibrillation are usually associated with hypertrophic cardiomyopathy. So this is a picture that I wanted to show you guys. Um, this is your hypertrophic cardiomyopathy with asymmetric septal hypertrophy. You can see how the septum actually bulges into the left ventricle. This is your left ventricle, this is the chamber, and this is your left atrium. So this septum basically bulges into the left ventricle, and the left atria is actually enlarged. Um, Regarding the histologic appearance, there's usually demonstration of disarray, extreme hypertrophy. You can see how the muscle fibers are much thicker, and characteristic branching of myocytes as well as interstitial fibrosis. Regarding the clinical features, they usually involve exertional dyspnea, syncope, palpitations, systolic murmur, mitral regurgitation, usually due to impaired mitral valve closure. And for the complications, so you're going to have heart failure because of diastolic dysfunction, sudden death in young athletes due to ventricular arrhythmias, and syncope with exercise, and this is due to obstruction of blood flow by the septum. Uh, for the treatment, you usually have cessation of high intensity exercises, ventricular relaxation therapy, beta blockers, or even non-dihydropyridine calcium channel blockers. Thirdly, we have restrictive cardiomyopathy. So, regarding the definition, it's characterized by a primary decrease in ventricular compliance, resulting in impaired ventricular filling during diastole. So, regarding the etiology, there's another mnemonic I have for you, which is puppy leash. So in puppy, you want to focus on the P, which stands for post-radiation fibrosis, and unleash in the first L. In the L, you focus on Loeffler syndrome, which is associated with a formation of large thrombi, and characterized by peripheral hypereosinophilia and eosinophilic tissue infiltrates, which release granule content. And this may cause endocardial as well as myocardial necrosis. As a result, you have fibrosis, thrombus, and finally its organization. So this may contribute to restrictive cardiomyopathy. In the E, you want to focus on endomyocardial fibroelastosis. So it's basically uh, a disease associated with children usually, and it involves diffuse fibrosis of ventricular endocardium and subendocardium in young children. And this may also involve the tricuspid and mitral valves. Then you have the A, which stands for amyloidosis. So this might be systemic or localized. You can have sarcoidosis as well as hemochromatosis, which is iron in the heart wall. And this damage is mainly associated with ROS generation. Regarding the morphology, so the ventricles are usually normal in size. They might be slightly enlarged. However, the atria are usually dilated due to pressure overload, and microscopically you have variable degrees of or interstitial fibrosis. And one of the main complications you need to know is congestive heart failure. And also, since the atria dilated, so you might have atrial fibrillation as well. So that's a possibility, and hence you can have thrombus formation and embolization. So regarding the other types, there are two specific that you need to know. So one of them is arrhythmogenic right ventricular cardiomyopathy. So it's an autosomal dominant disorder and it manifests with right-sided heart failure and rhythm disturbances that can cause sudden cardiac death. So approximately 10% of cases of sudden death in athletes have been ascribed to this entity. And morphologically, have a picture on the next slide. The right ventricular wall is usually thin due to myocyte replacement by fatty infiltration and fibrosis. A specific syndrome that you don't need to know, but I feel it's good that you know, associated with Naxos syndrome, which is a disease characterized by this type of cardiomyopathy, as well as hyperkeratosis of plantar and palmar skin. So this is a picture, and you can see the arrhythmogenic right ventricular cardiomyopathy. So the right ventricle is markedly dilated with focal, almost transmural replacement of adipose tissue and fibrosis, and the left ventricle has a grossly normal appearance in the heart. So this is the macroscopic features, and you have the microscopic features, which is where the right ventricular myocardium is replaced by fibrous connective tissue. So this blue thing is basically fibrous connective tissue as well as there's fat as well. And this also is a Mason trichrome stain. Sorry. The other type of cardiomyopathy is Takotsubo's cardiomyopathy, and this one is also known as broken heart syndrome. It's associated with sudden narrowing of the myocardium around the apex, causing ballooning of the apex, and during contraction, the pace remains akinetic and occurs usually due to increased sympathetic stimulation, especially in postmenopausal women. May also be associated with severe emotional distress as well. And clinical features may resemble myocardial infarction, but no arteries no artery narrowing is seen. Coming on to myocarditis, so from the term itself, you can see itis, which basically stands for inflammation, and myocardium, which is the muscular component of the heart. As a result, the definition is pretty straightforward, which is primary inflammation of the myocardium. Regarding the etiology, they may be divided into infectious, non-infectious, and other causes. In infectious, you need to know the examples of each because they're pretty high yield. For instance, you have virus. In virus, you can have Coxsackie A and Coxsackie B viruses. Specifically focusing on Coxsackie B, which is more important in case of myocarditis. You may have enterovirus, influenza, HIV, and CMV. In bacterial, the two most important are Lyme disease and Corynebacterium diphtheriae. In fungi, you can have Candida. In protozoa, you can have Trypanosoma cruzi, which is associated with Chagas disease. Uh, Helminths as well, Trichinella spiralis. So in non-infectious, you may have rheumatoid heart disease, you may have SLE, which is systemic lupus erythematosus, as well as giant cell myocarditis. Other causes may involve cardiotoxic drugs like chemotherapeutic and amyloidosis as well. So these are specific pictures associated with different types of myocarditis. So the first one, there's actually a type of lymphocytic myocarditis with edema and associated myocyte injury. In the second one, it's a hypersensitivity myocarditis. So this is associated with perivascular eosinophils. So eosinophil-rich inflammatory infiltrates can be seen over here. So these are all eosinophils. Over here, we have giant cell myocarditis with lymphocyte and macrophage infiltrates. So this is usually associated with extensive myocyte damage and multinucleated giant cells. And in the fourth one, we have Chagas disease. So in this, you have Chagas myocarditis, which is you can actually see a myofibre distended with trypanosomes over here. So that's a parasite in Chagas disease. And there's also mononuclear inflammation and myofiber necrosis. So regarding the morphology, so macroscopically in the early stages, it's usually normal, but it could be dilated or hypertrophied as well. In the late stage, it's usually flabby, pale necrotic foci or hemorrhagic lesions. Macroscopy, as mentioned, you may find inflammatory cells depending on the type of pathogen involved, possible amyloid depositions, cytopathic changes, especially in viral infections, and the presence of microorganisms as well. And complications of these usually involve heart failure, arrhythmias, chest pain, which may resemble ischemic pain. So that's all for me. Thank you.